So, welcome to the Kanski lecture series, Glaucoma Part 12, and in this part, we are going to discuss about the primary congenital glaucoma. Introduction. Primary congenital glaucoma is a rare with an incidence of 1 in 10,000 in many population. Boys are more commonly affected than girls. In most surveys, involvement is more often bilateral but frequently asymmetrical. It can be classified as follows: true congenital glaucoma, infantile glaucoma, and juvenile glaucoma. So basically, we have congenital glaucoma that is basically present from the birth, and it is mostly present in boys and have an incidence of about 1 in 10,000, and it can be divided into true congenital glaucoma, infantile glaucoma, and juvenile glaucoma. True congenital glaucoma 40% in which the IOP is elevated during the intrauterine life. So in this case the IOP is elevated in the uterine life also. Infantile glaucoma 55% which manifest prior to the age of 3 years. Juvenile glaucoma the least common in which the IOP rises between the 3 and 16 years of age. Primary congenital glaucoma is by definition not associated with other major ocular abnormalities. It is thought to be caused by impaired aqueous outflow due to the maldevelopment of the anterior chamber angle, trabecular dysgenesis. So basically, the congenital glaucoma can be primary and secondary as well. So the primary glaucoma is basically when the trabecular meshwork is itself defectively formed, whereas in secondary glaucoma other causes of the eye is congenital causes in the eye is causing the glaucoma. So it is usually sporadic, but approximately 10% are inherited in an autosomal recessive fashion with a variable penetrance. So it is an autosomal recessive. Several genes have been implicated predominantly CYP1B1, very important gene associated with the congenital glaucoma. The prognosis is dependent on the severity and the age at onset. Diagnosis: secondary infantile glaucoma can be caused by a range of a condition including tumors such as retinoblastoma, persistent fetal vasculature, persistent hyperplastic primary vitreous, and uveitis. So these are all the cases that causes the secondary infantile glaucoma. If a patient is having a retinoblastoma, if a PHPV, uveitis, these all can cause the glaucoma, but these are known as secondary glaucoma. Tip: primary congenital glaucoma is always treated surgically as soon as the diagnosis has been confirmed. So this is 11.58 is showing us the picture of iridoschesis mild moderate severe. 11.59 is showing a buphthalmos, means that there is a large cornea, and A is showing bilateral, B is showing the left eye only. It is slightly bigger. So how will you diagnose? Presentation usually occur when abnormality such as corneal haze, large or asymmetrical eyes, watering, photophobia, or blepharospasm is noted by the parents or health professionals. So there is a characteristically triad: photophobia, blepharospasm, and watering. Corneal haze is due to the diffuse edema secondary to the raised IOP or localized edema due to the break in the Descemet membrane. So there can be diffuse edema which is secondary to the raised IOP and localized edema due to the break in the Descemet membrane. Buphthalmos is a large eye as a result of stretching due to elevated IOP prior to the age of 3 years. The thin sclera often appear blue due to increased visualization of the underlying uvea. Complications include myopia and lens subluxation. So basically there is a large eye, and it is causing basically the elevated IOP in the age, because in an age less than 3 years there is a lot of the eyeball is really developing and it is increasing in size. So the raised IOP is causing the more increase in size than normal, and it causes the buphthalmos. So it will causes the increase corneal diameter. There can be the blue sclera as well, and complications that will follow up will be the myopia and lens subluxation. So what is HAPS striae? HAPS striae are the curvilinear healed breaks in the Descemet membrane. So HAPS striae is basically Descemet membrane breaks that has been healed. These are usually horizontal in shape, whereas the break in the Descemet membrane that is due to the trauma is vertical. Corneal scarring and vascularization. Optic disc cupping in infant may regress once IOP is normalized. Most infants exhibit no apparent cup. So basically, it is one of the condition where there is a reversible cupping. Means that a cupping is formed that can be reversed as well. Evaluation under general anesthesia is generally required. Intravenous ketamine lowers IOP than other agents. So ketamine lowers IOP than other agents. So this is showing a photophobia and blepharospasm in congenital glaucoma. A is showing congenital glaucoma. A is showing corneal haze. B is showing severe ophthalmos worse in the right eye, which exhibit marked diffuse corneal edema. C is showing HAPS striae. D is showing corneal scarring and vascularization. A is showing a normal infant angle, showing the iris root, prominent ciliary body band but no discernible scleral spur and trabeculum. B1 angle variant in congenital glaucoma, showing the iris root but not the ciliary body band due to the translucent amorphous tissue that obscure the trabeculum. IOP measurement should be performed first, optimally with more than one method. Perkins Tono eye care. It is preferable when possible for this to be measured in a conscious or sedated child. 10 to 12 millimeter mercury is normal in a child. Interior chamber examination with an operating microscope or portable slit lamp. So basically, patient is writer is just telling about what you will do under the general anesthesia. How will you investigate a patient? So you will take an IOP measurement, you will examine the interior chamber, you will examine the optic disc examination. If there is an asymmetry or cup disc ratio of greater than 0.3 is suspicious. Corneal diameter measurement greater than 12 mm prior to age of 1 year is highly suspicious. Gonioscopy using a direct gonio lens may be normal or reveal trabecular dysgenesis, vaguely characterized by an interiorly located iris insertion and hypoplastic appearance peripheral iris. So what you will see in a gonioscopy, you can see the normal angles or you can see the trabecular genesis, which is characterized by that there will be the interiorly located iris insertion and there is a hypoplastic peripheral iris. So you can see figure 11.62. A is a normal infant angle showing the iris root, prominent ciliary body band but no discernible scleral spur and trabeculum. So there is no trabeculum but you can see the ciliary body here. And B is showing one angle variant in congenital glaucoma, showing the iris root that obscures the trabeculum but not the ciliary body band due to translucent amorphous tissue that obscures the trabeculum. The old concept of discrete Barker membrane has not been definitively confirmed. Refraction can also be done in a patient in a general anesthesia. Treatment surgery is always required and is successful in 80 to 90%. Medication may be used as temporary or supplementary therapy. Caution is required with selection of medication in young children as most are relatively contraindicated. Goniotomy. Under direct gonioscopic visualization, incision is made at the midpoint of the trabecular meshwork. So basically the surgery is the mainstay of treatment in a case of a congenital glaucoma. Medical therapy is only used for the temporary measure. If the cornea is clear, you can perform goniotomy. Goniotomy is basically you just make an incision in the midpoint of the trabecular meshwork and allow the aqueous to flow through the trabecular meshwork. Whereas trabeculotomy may be necessary if the corneal clouding prevents an adequate view of an angle and is also an option when a repeated goniotomy has failed. A partial thickness flap is created and a Hermes trabeculotome is inserted into the Schlemm's canal and rotated into the interior chamber. So 11.63 is showing goniotomy. A white arrow show the cleft and black arrow show the direction. So this is a needle that has been at the point of the trabecular meshwork and you are just inside making incisions in the trabecular meshwork. So this is a trabeculectomy. So basically trabeculotomy is a procedure that is done in a congenital glaucoma when there is a corneal edema. So what you do is basically you make a partial thickness incision in the sclera, and after the partial thickness incision in the sclera, you make a put a trabeculotome. You just put it in the Schlem's gland and rotate it into the anterior chamber. A modification of the trabeculotomy is used in some centers. An illumination canaloplastic device is threaded into the Schlemm canal, followed by a 60 proline suture, which is then pulled into the anterior chamber, thus opening 360 degrees of the trabecular meshwork. The post-operative IOP using this technique is approximately 5 millimeter lower at 2 years than those obtained with the traditional approach. So basically, what you do in a modification is basically you place a catheter, and that is being followed by the into the Schlemm canals that has been passed with the proline suture in between. So what happen is that basically, you know, the Schlemm canal is basically surrounding all the perilimbal area. So you put from one side, and then you pass the suture from the other side. So there are two sutures, and then you just pull both sutures together into the from the anterior chamber. So it will just make incision in all the trabeculum, and it will lower the IOP more drastically than with the conventional method of trabeculotomy. Other procedures when angle surgery fails, including trabeculectomy, tube shunt implantation, and ciliary body ablative procedure. Monitoring of IOP, corneal diameter, and other parameter is required. Long-term amblyopia and refractive error should be managed. So, what is the differential diagnosis of a congenital glaucoma? If there is a cloudy cornea, so you can say it can be due to birth trauma, it can be due to rubella keratitis. Congenital rubella is associated with congenital glaucoma. Metabolic disorders such as mucopolysaccharidosis and mucolipidosis. Congenital hereditary endothelial dystrophy, sclerocornea. Large cornea is associated with megalocornea, high myopia. Epiphora, delayed or failed canalization of the nasolacrimal duct. Lacrimation secondary to ocular irritation, for example, conjunctivitis, aberrant eyelashes, and entropion. Next is the iridocorneal dysgenesis. So basically, these are the congenital diseases that is involving the iris and the cornea. So posterior embryotoxon. So posterior embryotoxon is basically mean the prominent Schwalbe's line. So what is basically the Schwalbe's line? Schwalbe line is the end of the Descemet membrane. So whenever there is a very prominent or anteriorly displaced Schwalbe line, it is known as posterior embryotoxon, and it is one of the features of the Axenfeld-Rieger's anomaly, and it can also be seen in Alagille syndrome. So you can see this is an Axenfeld anomaly. A is showing posterior embryotoxon, so this is a prominent Schwalbe's line. So posterior embryotoxon refers to a prominent and anteriorly displaced Schwalbe line seen as a thin gray-white arcuate ridge adjacent to the limbus on the inner surface of the cornea. It is innocuous, isolated finding in up to 15% of the general population, but is one of the features of the Axenfeld-Rieger anomaly. It is also seen in multi-system genetic disorder Alagille syndrome, in which the optic disc drusen is also common. Next is the Axenfeld-Rieger syndrome. Introduction. Axenfeld-Rieger syndrome is the umbrella term for the spectrum of disorders featuring bilateral development ocular anomalies. So this is bilateral disorder, Axenfeld-Rieger anomaly. So there are certain things. There is Axenfeld anomaly, there is a Rieger anomaly, and there is a Rieger syndrome. It is caused by a defective neural crust cell related processes during the fetal development. An abnormal endothelial cell membrane has been identified on the anterior segment structure in some patient. So it is just like an eye syndrome, but it is basically in the case of child, and it is in the bilateral case. The key implication of the syndrome is 50% risk of glaucoma. So there is a risk of glaucoma. That is why we are studying in this chapter. Associated variant in several different genes have been found, including PITX2, TAX6, FOXC1, and RIG-G2. That is, different genetic abnormality can give a similar clinical picture. Cases may be sporadic, but a family history is common. When inheritance is autosomal dominant with variable expressivity but very high penetrance, there is no gender predilection. Clinical features. Axon field anomaly is characterized by a posterior embryon toxon with a attached strand of peripheral iris that is best viewed with the gonioscopy. So basically, axon field anomaly is posterior embryotoxon plus the iris processes. So we can see in figure 11.66. A is showing posterior embryotoxon, B is showing gonioscopy strand, showing peripheral iris tissue extending into the cornea. Next is the Riger anomaly. Riger anomaly often manifests with an anterior segment appearance similar to that of iridocorneal endothelial syndrome. Posterior, so there will be the posterior embryotoxon. There will be the iris stromal hypoplasia, ectropion uvei, correctopia, and full thickness iris defect. So there will be the iris atrophy that will be manifested in the Riger anomaly. Gonioscopy in mild cases show axon field anomaly. In severe cases, broad leaves of the iris adhere to the cornea anterior to the Schwalbe line. Glaucoma develop in about 50%, usually during childhood and early adulthood. Surgical management is often necessary. Riger syndrome is characterized by the Riger anomaly together with the extraocular manifestations, malformations, that, as with ocular features, are caused by the defective neural crest cell related tissue development. Dental anomalies, hypodontia, few teeth, and microdontia, small teeth. So basically, the Riger syndrome is basically having all these features, Riger anomaly, with the extraocular features, systemic features. So they can mostly, there will be the dental anomalies, hypodontia, few teeth, microdontia, small teeth, facial anomalies, maxillary hypoplasia, broad nasal bridge, telecanthus, and hypertelorism. Other anomalies include redundant para-umbilical skin and hypospastia. Hearing loss, hydrocephalus, cardiac and renal anomalies, and congenital hip dislocations are rare. So this is the case of the Riger anomaly and syndrome. A is showing mild iris stromal hypoplasia. B is showing severe iris stromal hypoplasia. C is showing full thickness iris holes with correctopia in the right eye. D is showing severe correctopia in the left eye with the same duration. E is showing gonioscopy showing peripheral anterior synecdoche. F is showing the facial and the dental anomaly. So you can see microdontia and few teeth and hypodontia, small teeth. So next is a Peter anomaly. Peter anomaly is introduction. Peter anomaly is a rare but often severe condition that is bilateral in more than half of the cases. It is the result of the defective neural crest cell migration in fetal development. So there is a neural crest cell that has not been defected. Manifestation range from the mild to severe. Most cases are sporadic, though autosomal recessive inheritance has been described. So basically, in the case of a Peter anomaly, there can be the corneal involvement and the lens involvement. There can be the corneal lens adhesions that will be present. So there can be this type 1 only affect the cornea, type 2 show both corneal and lens abnormalities. Central corneal opacity or variable density, posterior corneal defect involving the posterior stroma, testament membrane and endothelium with and without iridocorneal or lenticulocorneal adhesion. So due to the defect in the cornea, there will be the adhesion of either the iris or the lens. Glaucoma occur in about 50% due to associated angle anomaly. Onset is usually in infancy, but occasionally in childhood or later. The prognosis tend to worse than in primary congenital glaucoma. Peters anomaly, A is showing corneal opacity, B is showing large central corneal opacity, C is showing the lenticulocorneal adhesion. Systemic association include craniofacial and central nervous system anomalies have been reported. Peter plus syndrome includes a particular constellation of the systemic abnormality. Then there is an aniridia. Aniridia is basically the iris is being deficient. Genetics. Aniridia is a rare bilateral condition that may have a life-threatening association. It occurs as a result of the abnormal neuroectodermal development. So in this case, the neuroectoderm is not developed secondary to the mutation in the PAX6 gene. PAX6 gene is adjacent to the gene VT1, mutation of which predisposes to the Wilms tumor. So the PAX6 gene is lies adjacent to the VT1 gene, which is associated with the Wilms tumor. So when both of these are deficient, they causes the aniridia with the Wilms tumor. So if the genetics, so there are certain genetics, they can be autosomal dominant inheritance, and there can be sporadic, and there can be the autosomal recessive, and every other inheritance have a different clinical features. So if there is an autosomal dominant, aniridia accounts for about two-thirds of the cases and have no systemic implication. Penetrates have been complete. All patient with the genotype will have a phenotype, but expressivity will be variable. So autosomal dominant will only have aniridia, where the sporadic can include Varg, previously known as Miller syndrome. So in the sporadic, there will be the syndrome known as VARG. So VARG means there will be the Wilms tumor, there will be the aniridia, there will be the mental retardation, and there will be the genitourinary abnormalities. And it is about present in about third of a patient. Children with sporadic aniridia have about 30% chance of developing Wilms tumor. Gillespie syndrome account for about 1% of the case. So in this case, the inheritance is autosomal recessive, but it is not caused by PAX6 mutation. There will be the cerebral ataxia and the learning disability. So in this case, there will be the cerebral ataxia and learning disabilities. Diagnosis. All patients with sporadic aniridia should have abdominal ultrasonography every 3 months until the 5 years of age, every 6 months until the 10 years of age, and annually until the 16 years of age to detect the development of the Wilms tumor, or until the molecular genetic analysis confirm the absence of a Wilms tumor. So if a patient is having a sporadic aniridia, means that the aniridia has formed after the development, after the birth. So basically there is a sporadic mutation. So what you have to do is basically monitor the patient too for the Wilms tumor. You can do it's a genetic analysis, and you can confirm that is there is any Wilms tumor mutation. Otherwise what you can do is basically up to 5 years you perform ultrasound every 3 months, up to 10 year every 6 months, and up to 16 year every 1 year. Presentation is typically at birth and with nystagmus and photophobia. So as the iris is being absent, there can be photophobia and nystagmus. The parents have noticed the absence of irides or apparently large pupil. Aniridia is variable in severity, ranging from minimal detectable only on retro elimination to total absence. 11.669 A and B. So A is showing partial and B is showing total aniridia. C is showing gonioscopy and aniridia, open angle showing remnants of the iris root. D is showing transillumination of the pseudophakic eye showing silhouetted ciliary processes. Lids often show meibomian gland dysfunction, cornea, tear film instability, dry eye, and epithelial defects are common. Limbal stem cell deficiency may result in conjunctivalization of the peripheral cornea. Total corneal central stromal scarring and vascularization may occur in end stage disease. So in case of the aniridia, there can be the lid anomalies, means there can be the meibomian gland dysfunction. There, in the cornea, there can be dry eye, limbal stem cell deficiency, or the corneal central stromal scarring. Fundus. Possible abnormalities include foveal or optic nerve hypoplasia and choroidal coloboma. So in fundus, there can be the optic nerve hypoplasia or there can be the choroidal coloboma. Gonioscopy, even in eyes with apparently total aniridia, usually show a hypoplastic or rudimentary fill of iris tissue. Lens changes can include cataract and subluxation. Glaucoma, 75% usually present in late childhood or adolescence. It is caused by the cynical angle closure secondary to the contraction of a rudimentary iris tissue. Treatment is difficult and prognosis guarded. So in a case of aniridia, the glaucoma, there can be the angle closure, and due to the rudimentary iris tissue. And in this case, the treatment is difficult. So in this case also, aniridia, the glaucoma, the medical treatment is not sufficient. You have to perform some surgery. So in glaucoma, medical treatment is usually inadequate. Trabeculectomy with mitomycin C or combined trabeculotomy and trabeculotomy have been tried in the past but usually fail to control the IOP. Glaucoma drainage devices offer the best chance for a long-term successful control of IOP. Diode laser cellular ablation may be necessary if the modality fails. Painted contact lens may be used to create an artificial pupil and improve both vision and cosmesis. Simple tinted lenses are alternative. Both may improve nystagmus. So you can just uh, wear a painted contact lens. Lubricants are frequently required for associated keratopathy. Cataract surgery is often required. A tinted artificial lens implant may be used to try to improve photophobia. Trauma to control nimbus should be minimized in order to preserve stem cell function. Prosthetic iris implantation has been described in pseudophakic and iridic eyes but may be complicated by or worsen glaucoma. Limbal stem cell transplantation with or without keratoplasty may be required. Refractive error, amblyopia, and squint should be managed. So in this case, basically you may have a limbal stem cell deficiency, and you can just do limbal stem cell transplantation. Then there is a glaucoma and phacomatosis. So phacomatosis is basically the diseases of the neurocutaneous disorders where there is an involvement of the eye as well, like in Sturge-Weber syndrome and neurofibromatosis. Basically the skin and the brain is being affected. So basically Sturge-Weber syndrome, encephalotrigeminal angiomatosis is a congenital sporadic phacomatosis. Glaucoma ipsilateral to the facial hemangioma develop in 30%, and in 60% of these IOP elevation occurs before the age of 2 years and may result in ophthalmos. So basically in a case of a glaucoma, basically in a case of Sturge-Weber, there is an angiomatosis. So there can be the facial hemangioma, and there can be and the glaucoma can also develop. So in eyes there can be like increased episcleral venous pressure. There can be the choroidal hemangioma. There can be the iris hemangioma as well. Glaucoma ipsilateral to the facial hemangioma develops in 30%, and 60% of these IOP elevation occur before the age of 2 years and may result in ophthalmos. So when it occurs before the age of 2 years, ophthalmos will occur. In the remainder, glaucoma may develop any time from the infancy to the adulthood. The pathogenesis is uncertain, but putative mechanism include trabecular dysgenesis in infant and raised episcleral venous pressure associated with arteriovenous communication and episcleral hemangioma in older patient. So how will you treat the glaucoma? In a case of a Sturge-Weber syndrome, medical treatment alone may be adequate. Goniotomy may be successful in eyes with angle anomalies. Combined trabeculotomy and trabeculectomy gives a good result in early onset cases but carries a relatively high risk of choroidal effusion and suprachoroidal hemorrhage. Other surgical options may be utilized. Next is the neurofibromatosis type 1. Neurofibromatosis is a disorder that typically affects the cell growth of a neural tissue. Inheritance is autosomal dominant with irregular penetrance and variable expressivity. Glaucoma is relatively rare and when present usually unilateral and congenital. So basically the patient have a neurofibromatosis of type 1, which basically affect the cutaneous and the membrane. But glaucoma is also present in the case of NF1. About 50% of the patient with glaucoma may have ipsilateral plexiform neurofibroma of the upper lid or facial hemiatrophy. Various mechanisms have been identified, including congenital angle anomaly, which may be associated with ectropy on UVI. So you can see figure 11.71. You can see one is showing neurofibromatosis type 1, left facial hemiatrophy and multiple neurofibromas. B is showing congenital ectropy on UVI. And 11.70 is showing the glaucoma in the Sturge-Weber syndrome is left hypophthalmos, and B is showing the episcleral hemangioma. So that's it for the glaucoma part 12. See you in the next lecture.